Hello, I'm Donal McCauley, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Scotland, and I'm talking to John Gillies. Fáilte a sheáin agus dé go imagine.
Well, mur an tanger son a curv akal of Ian of Medics Voices. Many thanks for the invitation to do an interview to Medics Voices. I suppose we'd better do this in English for the audience.
Yeah, absolutely. Well, look, this is a good point to start here because let's talk about your childhood because you were born on the Hebridean Gaelic-speaking island of North Uist. Tell us about that.
Yes, I was born in Lochmaddy, Isle of North Uist, and at that time it was really predominantly a Gaelic speaking. So Gaelic was my first Scottish Gaelic was my first language, and I learned English more or less when I went to school, in fact, and where the teachers weren't allowed to teach in Gaelic, or they didn't allow us to speak Gaelic. It's part of the minoritization of language that you see all across the world. So also it was a world apart. We had no electricity, and there wasn't any electricity there until 1969. So when we moved to the mainland when I was 8, it was my first exposure to the new technology when I was able to put on a light switch at the wall and the light in the ceiling came on. So that was my first experience of electricity and technology. So, but it was a very traditional community, and yeah, everyone worked together. My grandparents were crofters; they were small farmers. My mother was a nurse, and my father worked in the post office as a clerical officer, and he got promotion, which is why we moved. So I'm the first person in my family to go to university, in fact.
So where did the interest in medicine come from?
Um, it's hard to say, what goes into making these decisions, especially when, like me, there's no background of medicine in the family to guide you or to put you off, because both things happen, of course, in medical families. I think a lot had to do with our family's experience of ill health. Nearly all my father's family, including my father, had tuberculosis. At some stage, one of my father's sisters died from what was probably miliary tuberculosis before the availability of triple therapy in the 1940s. My father had TB in the 1950s, but at that time, luckily, it was curable, of course. But I remember him going away for 3 months to a sanatorium in Stornoway in the boat and coming back better. So there was that sort of background, a and my mother was a nurse, and so I remember her going into hospitals and coming back and talking about patients. So probably these family background issues, had a big effect on me. Um, and the idealism of youth, in fact, when you leave school and you want to make the world a better place as well. I think that was part of it too.
So you went to Edinburgh. Tell
Mm.
us about medical school in Edinburgh.
Medical school in Edinburgh, it was quite a shock because by that time my father was a head postmaster and we were living in Glenrothes in Fife, where in fact the school system was fantastic. At that time, we had very, very good science teachers, and I think that also played a part in guiding me towards sciences and medicine. So I went to Edinburgh, I think because it was the closest university to where we lived. And I think what struck me first of all was that many of the students in Edinburgh then were from Edinburgh. They'd been to Edinburgh public schools, and I actually thought they were all English when I went because their accent was so completely different, both to my sort of Gaelic island accent and the accent of the people in Fife. Um, so that took a bit of adjusting to. And luckily, there was a very active Highland Society there, which I became part of. I think I really only became seriously interested in medicine properly when the clinical years started. I did an honours degree in pharmacology, and that was interesting because it taught doing a intercalated year teaches you that medicine is not science. That's what it taught me. That it was. I had a very rigorous pharmacology tutor called Bernard Ginsberg, who, when we did critical analysis of papers, and then I realized what we're doing in medicine used science, but it was not really science in the sense that pharmacologists or a biochemist would know science. So, but when we got to the clinical years and I began to see patients, then I became really much more interested in the business of medicine. And I stayed on in Edinburgh, and I think I decided I wanted to be a hospital physician then, so I did my MRCP, and then things changed, of course, after that.
Yes, indeed. I mean, you talked a moment ago about the idealism and the optimism of youth, and so you went to Africa. Tell us about that.
Yes, well, it was a, at that time. I was my girlfriend at the time subsequently became my wife. She was, in fact, her parents were in the colonial era, um, sort of civil servants in northern Rhodesia, which is now Zambia, and she'd been back to Africa on an elective to, I think, Tanzania. So we had a look at it, uh, and I knew a few African people in Edinburgh as well, so I thought it would be interesting to go. But I think Mary was probably the one of the main factors in getting us there. So we both did the 3 month diploma course in tropical medicine and hygiene at Liverpool, and then jobs came up in Malawi and Central Africa, and we were. I think our official title was General Duties Medical Officers. So we ran a sort of district general hospital near the Mozambique border, in fact, with a lot of very competent Malawian staff, clinical officers, and nurses. There was no medical school in Malawi at the time, so all the doctors were either expats like us or Malawians who had been to the UK and other countries and had come back. There is now a good medical school in Blantyre. But no, it was a really interesting 3 years, and we were both quite sorry to leave. But there are factors which drew us home.
Well, then you had this transition back to Scotland and a new career. Tell us about that.
Yes, so I think by that time I decided. I think one thing about working somewhere like Africa is that you do become quite independent because you have to make decisions sometimes without much support. Although we did have good surgeons, we had excellent Malawian surgeons and obstetricians and physicians. But basically, we were nearly 100 miles from the nearest large hospital, and so looking at the situation here. I thought it would be problematic to go back in as a junior doctor. Also, I decided I didn't really like hospitals by that stage. I thought I didn't really want to spend the rest of my life in a large, overheated hospital environment. So, in fact, a job came up with Alistair Donald, who's then regional advisor in Edinburgh and subsequently chair and president of the Royal College of GPs as a trainee. So I had an excellent year with Alistair and his colleagues, some of whom I'm still in touch with, in Leith in Edinburgh. And then after that, because I'd really always, besides medical school, I'd always lived and worked in rural areas. I began to look for posts in rural Scotland, and I had 11 years in Galloway on the A75, the road from Rara in Northern Ireland, of course. And then the rest of my career, about 18 years in Selkirk in the Scottish borders, where I still live, in fact. Yeah.
Well, you give me a hint there as to where your interest came in the college and in academic general practice. So tell us about how you got involved with the college.
Well, I did the exam, of course, when I was a GP trainee, and a, I think when I was in Galloway, we were working a pretty hard rota. I was on a 1 and 2, 1 and 3 rota. We had we had a rural hospital to look after with the other docs. There were no consultants there besides a surgeon, and we did some intrapartum obstetrics. So it was really when I moved to Selkirk in 1996 that I became interested. I became a member of the local faculty, and I began to go to meetings, and I became interested in a few things. A rural training as well. How do we train doctors for rural parts of Scotland and indeed the wider world? And I published some work with the help of the college, really, with Dr. Mary Scott, who was chair of RCGP Scotland at the time. I was a member of council, and we, with encouragement from her and the late Dr. David Blaney and Dr. Stuart Murray, we got some funding to do a project called The Essence of General Practice, which eventually we published with Stuart Mercer, Graham Watt, Mary Scott, and the International Futures Forum. So that was an attempt to set out, I suppose, a kind of practical philosophy for what were the core values of general practice at that time, which I think are still rather similar, to today. I think, but every decade, perhaps you have to redefine what they are in the context of your structures and what the expectations, the technology, the therapeutics, and so on. So that was how I became interested. So I'm very grateful, particularly to Mary Scott, for introducing me to stimulating people within the college. And after that, I became chair of the college in RCGP in Scotland for 4 years, which was really interesting and really challenging, I would say, as well. But I don't regret any of it.
I was always impressed with your fresh new approach to the college, which was quite different to this sort of establishment approach. And when I look at your work, you were way ahead of your time. You must look at some of what you hear and see now and think, my goodness, we were there 15 years ago.
Well, yeah. What do philosophers say? The modern philosophers say the ancient Greeks are always stealing our ideas. So the future is always there in the past as well. I think looking some of the core values that we looked at in the Essence project were things like continuity of care, which continuity of care and a generalist approach. So this was in between 2007 2010. So and I think these issues, continuity and a generalist approach, a focus on the patient, not just the disease, I think have come to the fore more recently, certainly. There's more evidence now for the importance of continuity, the clinical importance of continuity, reducing mortality, morbidity, attendance, and so on. And also the concept of the expert generalist, I think, has come to the fore. So I think that was all there within the Essence work that Stuart Mercer, Graham Watt, and Mary and I did in the, between 2005 and 2010. And after that, Martin Marshall set up the Commission for Generalism. I think that was when I was with the Health Foundation, which tried to define it. But it's interesting, though, despite all that, Donald, we're still at the stage where in the NHS, certainly in Scotland, the UK, we've still appointed far more specialists and super specialists than generalists, and the numbers of these specialists and super specialists, all of whom I'm sure are doing a wonderful job, has grown remarkably. And the number of GPs really has stayed static. So despite all the work that the college and other organizations have done, it hasn't always translated into action in terms of where the funding goes. The funding for general practice has dropped a bit, really, in percentage terms recently, rather than risen. So there is a message there, perhaps, for the college about how it actually makes things happen. I think we're sometimes quite good at talking evidence and theory, but the practical effects. I think if I have a disappointment at the end of my career, it's that translation into spending more money in general practice hasn't really happened, despite there being lots of evidence that will provide better care and save resource for any health system.
Now let's take a little diversion for a moment to talk about the breadth of your interests, because a way back you did an MA in ethics and law.
That's correct. Yes, yes. I think I was fortunate when I came back to Selkirk, and I was doing some work with NHS Education Scotland at the time, which was then organised into local deaneries. And I met a Professor Kenneth Boyd, who was Prof of Medical Ethics in Edinburgh, who's actually a theologian rather than a doctor. And I became very interested in ethics, because one of the things you realize quite quickly, certainly in general practice, is that the facts don't always tell you what to do. You know, the evidence doesn't always give you a clear path forward, and we need ways of sorting out what's the best course of action. So I did this master's in Kiel, and really enjoyed that. Interesting colleagues, interesting teachers. It was quite an undertaking. Perhaps if I'd realized what a big undertaking it was, I might not have done it, you know, but you're always wise to these things after the event. And I was very grateful for the support of Mary, my wife, who's also a GP. She took up some of the slack in the practice when I wasn't there. So out of that came an occasional paper that I published on the consultation in general practice. Which is still available through on PubMed, in fact. But it was basically an argument for the doctor-patient relationship, a broader approach to that consultation, taking into account the patient, her family, her culture, her community, and so on. So it goes through, called different things at different times, isn't it? The holistic approach or whatever, but it involves using imagination, moral imagination, empathy, and compassion, as well as the hard clinical skills which you need. So I found that quite, and certainly that time has shaped my practice ever since. And I've published a little in the various journals, including the textbook of ethics in general practice, which Andrew Papanakitis and John Slider, anyways, published a couple of years ago. So it's been an abiding interest of mine, certainly.
And you clearly have an interest in the arts as well, because you were involved in an initiative with poems from general practice.
Yes, poems for and of general practice. So we're just actually, so this here is that coming up on the screen at all, is it? Yeah. So this is a Tools of the Trade, Poems for New Doctors. So this was an initiative. It wasn't my initiative to start with, but it happened when I was chair, and one of colleagues in Hoyk, a GP called the late Pat Manson, he had this idea of using poetry more in medical humanities, in training both undergrad and postgrad. And one of his partners, Leslie Morrison, suggested after he died that we could get a poetry book for new doctors in Scotland. So, and it is really popular with some graduates. It's hard. It's a very hard initiative to assess. So you can say, what does this achieve? You know, and it's very hard to measure that sort of thing. You know, what do they say? Not all that is measured is important, and not all that is important can be measured. And I think there's no doubt through anecdotes that this has a significant effect on some people. And I think, I mean, the medical humanities just give us different ways of seeing our patients and different ways of seeing the world. And they can provide a kind of intensity of gaze as well. They appeal to the emotions and the intellect, good poems. So I think I think they can really enhance our understanding of our patients and the world our patients live in. One of the things I realize in any career where you try and have leadership is that there are no solo climbers, are there? You always need people around you and people hauling you up. If you're hauling people up, people are hauling you up. So I think that's a really, really important point.
Now, you're still involved with a number of initiatives with the University of Edinburgh.
Yes, a couple. The main one that I'm involved in is the Global Compassion Initiative, which is not just a medical initiative; it's a broader initiative across the whole university and sits within the Global Health Academy, led by Professor Liz Grant. And that's just an attempt to raise the profile of compassion and stress how important it is in the lives of us as social animals. And people think compassion is something kind of soft and cuddly and so on. But in fact, compassion is recognizing discomfort, pain, distress, suffering, all of which we see as GPs, but also they're about the wider world and taking some sort of action to address them. And it doesn't have to be a world-changing action. It just has to be sometimes acknowledgement that people are in distress or taking some simple action to help them. And that's I mean, the thing I tend to say is that none of us would be here without the compassion of our parents, particularly our mothers, you know, in getting us through the first part of our lives. And we've had various initiatives. We had a really interesting evening at the Edinburgh Futures Institute in March, which I chaired on compassion, relationship-based care, and artificial intelligence, because we are now in this new world of artificial intelligence with Stuart Mercer, who a professor of primary care and multimorbidity, Liz Grant, and Paquita de Zulueta, another well-known GP from London, and also Shannon Vallar, who is a philosopher with a long-standing interest in Aristotelian philosopher with a long-standing interest in technology and its effect on human beings and the world. So I don't know if we came to any clear conclusions, but the general feeling was that the potential advantages of artificial intelligence also had to be weighed against some of the potential disadvantages, in that artificial intelligence is not human, and what we have to try and develop in these very difficult times we live in are better relationships between human beings, which include compassionate and respectful relationships.
Now, finally, let me bring you back to the very beginning, because you're still involved very closely with the community in North Uist, and indeed you were back there to recognise some of the MacLeod family of medics. Tell me about your links now with the North Uist community.
Well, I'm going up there on Saturday, in fact, for a week, and so I still have family there. My sister and her husband and my niece are still live there. I'm involved. I'm a trustee of an organisation called Gàidhlig Uist, the North Uist Historical Society, which is involved not just with history, but also we've done a project recently on what contributes to well-being in an island community, with a small grant from the British Science Association, which comes originally from Wellcome, in fact. So I'm involved in that sense. I mean, it is one of the reasons that I'm still interested in it is because of the language and culture, which are my culture and my language, but also because it still has a remarkable sense of community. You know, people in these quite isolated places, life only works if you work as a community. The crofting communities work because they help one another at harvest time, at lambing, and so on. And one of the senses I have from my childhood is of that community, of being able to go into people's houses without knocking and things like that. Now that's changed a bit, but I think there's still something to be learned from that, and I still find it very refreshing to go back there and also it's just such a beautiful place as well. The beaches are fantastic. You can get what they call a Shach Shors, the Shia and La, 7 sorts of weather in one day. And that's also refreshing in a very physical sense. So it's still very important to me.
John, you spoke there about the community in the island community, but of course we have a wonderful community in family medicine, of which you've played a major part. One of the things that we don't often get the chance to do is to thank those who were a great inspiration. And to me, it's a great pleasure to talk to you today because you don't realize what a fabulous inspiration you've been to me throughout your days in general practice in the college. Thank you very much indeed.
That's very kind of you. That's very kind of you. It's been really nice speaking to you. Thank you for the opportunity.